I would like to introduce a long-standing speaker in our multiple geriatrics series who sets the standard for outstanding and evidence-based information. Dr. Stephen Thielke is a geriatric psychiatrist and health services researcher in the Department of Psychiatry and Behavioral Sciences at UW School of Medicine. He conducts research about dementia medications, depression and pain in older adults, and the use of monitoring technologies in healthcare. And he's here today to talk to us about depression in the aging process. Welcome, Dr. Thielke.
Thank you, Barb. It's a real treat to be here. And thank you all for joining today. It's a beautiful weather wherever I assume you are on the West Coast. And thanks for taking a little bit of time to be indoors to learn about depression in aging. This is not the most exciting topic to talk about because it's kind of a downer, as you may guess, but as you all know, I'm sure it's a very important one to consider and to address in various settings that you work in. So if you have urgent questions, please just feel free to put them in the webinar chat as we go, and I'll keep an eye on that, and then we can also have time for questions at the end. So wanted to focus on a number of topics today. First of all, some common misconceptions around what depression is and how it works. To look at the life course in a very big picture, to talk about what depression is and is not in a purely clinical sense, then to spend a little time thinking about what it really feels like to be depressed, since the clinical part of it doesn't cover the whole experience. Then to look at the onset and resolution of depression based on age, and then to spend a little time talking about which treatments have the best evidence, and at the end to focus some on suicidality and how to interact with patients who may be suicidal. I don't think that topic is covered anywhere else in the series, and that one definitely is not super fun to talk about or think about, but it really is an important thing to be ready to deal with any of your patients. So there are some common ideas that people have about depression and getting older that you hear in the mainstream. When I talk to families or relatives of my own and hear that an older person is depressed, the usual response is, well, that's just natural. It sucks to get older in certain ways, and your friends are dying, you can't do what you used to do, you're homebound, so of course you'd feel depressed. We'll be challenging that one. Also, there's a common usage of depression that's just like having a bad mental hair day, and if you assume that if somebody is down, that they may be depressed, but we'll see that clinical depression really is a different type of thing. That's a syndrome involving different types of symptoms. There's also an assumption that physical health and depression cause one another. Same kind of idea about old age being a miserable state, and we'll challenge that. The most common misconception I hear about suicide is that if you ask somebody about their risk of self-harm, that's going to put them at risk. It'll give them ideas about what they can do. And in fact, that's not at all true. And I'll try to convince you that it's important to assess suicidality in everyone, and also to have a plan ready for what to do if someone says they're thinking of taking their own life. And then finally, we have these drugs called antidepressants that have some benefit, but I wanted to give real context for the efficacy of antidepressants and talk about how they work and how the dosing of them can impact their outcomes. So this is not depression per se, it's rather about well-being. And this is absolutely fascinating research that I think really flies in the face of what you might expect about getting older. When I talk even to the psychiatry residents who are mainly in their 30s about the aging process and ask them, what do you think the psychological experience is as you get older? And almost all of them say, yeah, I think you probably get more miserable as you age because you can't do what you used to do. You're not having as much fun. Your life is kind of boring and you get sick and maybe people are dying. And then I ask them, do you actually know some old people and what's their life like? And usually the old people they know are having a pretty good time, and they kind of rethink this. So if you really do the investigation of this question, you find a very interesting trend, which is that your happiness, which is the on the y-axis here, happiness uh, starts out pretty high in young age and then drops off quite a bit when you hit early adulthood in your 20s, and then worsens in your 30s and hits a low point in your life at about age 50 to 53. And then after that, gets a lot better. So people who are in their 70s or 80s look like they're even happier than the people who are adolescents and don't know anything. So this is something to look forward to, actually. I'm struck by the big increase between 53 and 54. I just turned 54 last month and been looking forward to it. And sure enough, I feel pretty good. Not that everything's smooth sailing, but that maybe you can expect things to get better. So this really is the big picture context. And if you work with older adults, you want to assume that they can have a great quality of life, and that in fact the older they get, their quality of life may get even better and better. So that's the positive message. There's also very interesting data about just how long people live around the world. And there's a little too much on this slide to spend a bunch of time on, but what you can see is that how long people live depends almost exclusively on what amount of income their country has. So people from high income countries live a long time, from low income countries live a short time. But on balance, everybody lives a lot longer than the average lifespan before about 1800, when it was about 35 to 40 years of life expectancy. So we are getting huge number of more years of life than people did in the past, and people have to find ways of occupying that time. So simply, working for a while, reproducing, and then getting old and dying isn't the story. In fact, there's a lot to life that continues, and especially if you're from one of these higher income countries, you can expect to live about 80 plus years. But if you're from a poor country, it's considerably less. So there's something in that, and it mainly has to do with the level of social equality across those countries, and it is less impacted by healthcare or genetics. So to put one final point on this theme, this I think is absolutely fascinating work about how your expectations of getting older impact your life. So they took people who are in their middle age, about age 50, and asked them questions about self-perceptions of aging. Uh, and they categorized people as having positive self-perceptions of aging, that's PSPA on the graph, or low expectations. And these are the kind of questions you'd expect, like, getting older is a great opportunity to learn new things and have fun, compared to, getting older means getting sick and suffering and being miserable. So when they studied these people's expectations, they found that they could categorize them as either high or low. And then they actually tracked how long they lived. And even after they adjusted for all the health characteristics, like number of diseases, number of medications people were taking, socio-demographic characteristics, the finding is really quite clear that people who have positive expectations of aging live about 7.5 years longer than people who have low expectations. One of the greatest cases of a self-fulfilling prophecy ever. And if you wanted to take home from this talk and you're planning to live a long, happy life, I would make it this point that if you expect to have a good time as you get older, you probably will. And if you don't expect to have a good time, it's going to take years off your life. So expectation is really crucial in the experience of getting older, which is different than major depression. So I don't have any simple, straightforward explanation for why people become depressed. Probably a combination of genetics and bad luck and environmental factors, although we really don't understand all of them well. But we do know that people become depressed at times. And the more likelihood, the more episodes you've had of depression in your life, the more likely you are to have another. That's kind of a no-brainer. But when people become depressed, it's not just feeling sad or bummed out. It's a whole syndrome that involves multiple types of symptoms that are present for a long period of time. So in DSM-5, in order to meet the criteria for major depression, you have to have 2 weeks or more, all day, every day, of low mood or apathy, just not caring, and then 5 or more of those symptoms. So sleep problems, trouble with appetite, concentration off, interest being off, low energy, guilt, doing fewer activities, having thoughts of death or suicide, and then psychotic experiences. And if you have 5 or more of those every day for 2 weeks, and you have some functional impairment, you would meet a diagnosis of depression. You can tell this is different than just having a bad day here and there or being upset about politics. This is really a full constellation of findings that have a major effect on people's life. I'm going to go quickly through some other assessment tools. This is the Geriatric Depression Scale. That's 15 yes/no questions. You can look at those and see how they focus on a little more social, functional issues and less on symptoms of distress. So not getting out of the house, not doing activities, being bored. So it's another formulation for what the experience of depression would be like for older people. Then this is another scale that's used in a lot of studies called the CESD. You can see it's got 10 questions, all rated 0 to 3, and they all sort of relate to those diagnostic criteria, but they're a little bit different way of coming at them. The tool you may have seen used in a lot of primary care settings is the PHQ, Patient Health Questionnaire. It's a screening tool when it's in its two question form. And this is what people would get like every appointment to fill out. So these 2 questions, the first about interest or pleasure, second about feeling down, depressed, or hopeless, and you rank them 0 to 3 based on how frequently this happens. And if you answer 3 or more total, then the recommendation is to complete the PHQ-9, which is basically those 9 elements of a diagnosis that I presented before. And once again, it's 0 being not at all to 3 being nearly every day. So people rank these. The maximum score would be a 27. And if you have a 10 or more, then that's probably major depression. Not necessarily so, but probably, and that would merit further investigation. If somebody, happens to have a 3 on the PHQ-2, they could potentially only have a 3 on the PHQ-9 also, in which case you'd say they just weren't very interested in things and had a low mood. But usually all of these things go together. and people will endorse symptoms across all 9 categories. So the other psychiatric conditions that can look like major depression are numerous, and you have to keep these in mind. Although, frankly, most of the time, if somebody comes in and their main complaint is depression, they probably have depression, but you need to make sure they don't have something else. So, bipolar disorder, when it's in its depressed phase, looks a lot like major depression. Bipolar disorder is alternating periods of mania or hypomania, where people are like the opposite of depressed, have too much energy, don't need to sleep, get a lot of things done. Sometimes they become very pressured and grandiose and psychotic, but they alternate generally with times that they're depressed and can't get going. And as a snapshot in those low times, they look very much or almost identical to people who have major depression. So it's important to sort out if they have bipolar disorder, in fact, and if they do, it's a totally different treatment approach. If somebody is older and having early dementia or other types of cognitive impairment, it can look like depression because they're just not doing very much. They're not engaged in their life. They seem to have no zest for living. But when you ask them, usually they'll say their mood is just fine. So this is a common issue we see in geriatrics where the family will say, I think he's depressed. And we'll talk to the patient and they're not depressed. They're just not remembering things and not able to do the things they used to do. If somebody has lost a loved one, especially a spouse, they can have a lot of mood changes. So it can be tricky sometimes to separate out grief from major depression. But traditionally, and in almost all cases, grief does not involve any thoughts of death, and it tends to have a more mild presentation of the hallmark symptoms that are in depression. There's more fluctuation. So somebody would, feel down a lot of the time when they're thinking about their loved one who has died, but that will alternate with times that they're able to do okay. Grief tends to resolve more on its own also. So adjustment disorder is mood changes that are not as severe enough to qualify for major depression, and it's the result of a specific event. So there has to have been a cause that happened prior to the worsening in mood. And that, as we'll talk about, is very different for major depression in terms of how you treat it because there are no medications that work for adjustment disorder. And then finally, there's a condition called dysthymia, which is a chronic low-grade depression where you have low mood more days than not for 2 years or more, but you don't have 2 straight weeks of feeling down or blue. You can have both major depression and a dysthymia, and that is called double depression. But more often than not, people will have one or the other. And I'm not going to talk about differences in treatment there, but there are some medications that work better for dysthymia than for major depression. So all of this is kind of dry and clinical, and it doesn't really tell you what it's like to be depressed. And I work with a lot of people who are depressed, and honestly, I find it very hard to imagine what it's like to be in their shoes. Like you just think, why can't you just perk yourself up? Or, things aren't that bad. Why are you so bummed out? And I think it's one of those things that if you haven't been there yourself, you really can't empathize fully with people who are going through major depression. This is nicely and much more artistically put by William Styron, a novelist who suffered from major depression and who wrote about it in his book called Darkness Visible. So I won't read this quote aloud, but you can see how he describes it, that it's you're it's different than just having a low mood. It's like something that takes over your entire body and fills you with this sense of murk or of being completely sapped. Sometimes people use the analogy of swimming in concrete is what they're trying to do. So somebody's depressed, it doesn't work just to tell them, hey, perk up a little bit. Um, Steron also observes that it's really hard to describe what this mood state is. He wrote a book on it, but he acknowledges that it's almost beyond description because the process gets in the way of your ability to see yourself, and you're not able to conceive of what it would be like. The theme of pain is definitely important when people talk about depression. Uh, Emotional pain is extreme and persistent emotional pain might be a reasonable definition of what's happening in depression. And I came across this quote by Bob Geldof, who had an episode of depression after his marriage fell apart. And he nicely articulates how the body's perception of physical and of mental pain often go hand in hand, and you really can't separate those out. So we'll talk about pain again when we discuss suicidal thoughts. This little picture kind of, I think, nicely sums up what it would feel like to be in a depressed state. It's not just you, but you realize that there's other people around you who are really kind of having a good time and doing all right, but you feel like you've been cut out completely. And that's the same type of experience that people with chronic pain will talk about. They feel like they've been excluded from the world of those who function more normally. So I wish I had more articulate ways of characterizing depression, but I think it's one of those things that's hard to put your finger on, and in fact hard to conceive of what it's like. All right, I want to share some data with you now about how depression changes across the aging process, and in particular to look at the role of physical health in this. So this is data from a large study called the Cardiovascular Health Study that I analyzed with my colleague Paula Deer, who's a biostatistician, and we were trying to separate out how depression and physical health interacted over time. So there were two questions that we looked at. First of all was a self-rated health measure. So it asked people to say how healthy they thought they were on a scale of excellent, very good, good, fair, or poor. That's E, V, G, F, or P. And then to assess their mood in response to questions on the CESD. It's a scale I guess that's the one I presented before. So we categorize people as being either healthy if they said their health was excellent, very good, or good, or sick, which is poor or fair or poor, and then categorize them as being depressed if their CESD score was 10 or more, or non-depressed if it was lower. And then you can see from those boxes that you could either be healthy non-depressed, healthy depressed, sick non-depressed, or sick depressed. And then there was a fifth state known as an absorbing state, which is death. So we were curious about how the different states would relate to mortality risk. This is a lot of arrows. But what you can see is if you've got these four categories, each of them is a state, so what it's called, you can go from any of those four categories to any of the remaining four categories, or you can stay in your category. For instance, if somebody was sick non-depressed on the bottom left, they could remain in that state the next year, or become healthy, non-depressed, or sick, depressed. You get the idea. Or you could die, and of course you don't come back from the D state. So it's a lot of arrows, and most of them are kind of very low probability and not very interesting. But when you graph them across age, you see some interesting trends that I wanted to go through. So the x-axis here is the age of the participants, and the y-axis is the probability of each of these outcomes 1 year later. So if you, on the top left, these were people who were not depressed, and then 1 year later they were depressed. And we separated out whether they were healthy or sick to start. So the blue line there shows that as you get older, a little tiny difference, little increase in your likelihood of becoming depressed if you're a healthy person, but not really. I mean, it's between 7% and 8 point something percent. So not much change there. And if you're sick, your probability of being depressed is about twice that. So it really is considerably higher, but that also doesn't seem to change much during age. So this really contradicts or negates the idea that as you get older, you're going to become depressed. Just that doesn't hold up. And even people who are in their mid 80s, some of them become depressed, but at no higher rate overall than they did 20 years earlier in their life. If you look on the top right graph, this is the probability of remaining depressed. And you can see that those are about the same. There's a slight difference, but not that much. And as you get older, if you're healthy, you have a slightly higher increased likelihood of remaining depressed. But if you're sick, it doesn't seem to matter at all. This also shows that if you are depressed, you're probably going to be depressed the next year. And this is a challenge in treatment because these people were interested enough in their health to be part of a large study. And many of them were receiving treatments for depression, and yet the majority of them remained in a depressed state year after year. But the big difference that you see across age is the likelihood of returning to a non-depressed state. So if you're sick, as you get older, you're a little bit less likely to return to being not depressed. But if you categorize yourself as healthy, then the older you get, the much less likelihood you have of bouncing back from depression. This is kind of weird, because you'd think that people who are sick might get stuck more, but in fact, people who are who are not sick, who are categorized themselves as healthy, as they get older, have a lower likelihood of getting back. So this points to a significant age trend. And finally, to look at the risk of dying, and this is really a surprising finding. If you look at the likelihood of dying among people who are depressed, if you're healthy, then being depressed increases your risk of death by between 1.5 and 2 times. And that decreases over time, but is still pretty significant. So if you're healthy, being depressed kills you, to put it bluntly. Whereas if you're depressed, it doesn't seem to have any effect, or maybe is even mildly protective. So another kind of unexpected finding that suggests that being depressed is a little more complicated a situation than just like having another medical type illness that would increase your risk for dying. So to put all this together, the basic take home that fits with that happiness data that I showed earlier is that as you get older, your risk of depression does not increase, but that if you're sick, the older you get, you have a higher likelihood of becoming but not remaining depressed, and that aging Uh, as you get older, it does not, you would not say that it causes depression, but it is associated with a higher likelihood of remaining in a depressed state, especially if you're happy, if you're healthy. So the if you boil all this down, what you would say is the goal of addressing depression in later life would not be around preventing depression so much as ensuring that people who have depressive symptoms are able to bounce back from it, because otherwise they're getting stuck in a state where they are depressed. So that brings us then to treatment. And treatment's a little bit counterintuitive and frankly frustrating when you look at the real world outcomes of how effective our treatments are. As I noted earlier, a good 60 to 70% of people in this study who were depressed or depressed the next year. That means they're whatever treatments they're getting are not working. And the logic behind treatment often does not make sense in terms of what you do for it. So you'd assume that if you're a little depressed, you could get a little treatment, like a little dose of a medication or antidepressant or a short course of therapy, and that would fix you up. And that if you had a lot of depression, you would need to have a lot of treatment involving more medications and longer doses, longer courses of therapy, and that would be effective. Like you can titrate the benefit of treatment based on the severity of symptoms. When people have looked to see what the effect of uh, medications, especially, is on outcomes, what you find is kind of surprising, which is that at lower stages or lower severities of depression, treatment and placebo, like drug and placebo, seem to have essentially no difference. That is, the drug does not seem to fix minor depression. So even using a full dose of a drug doesn't seem to help people get better any more than a placebo would. And that the cases where antidepressants have the most effect are those where there is a high degree of symptoms, not only high enough to qualify for a diagnosis, but even considerably higher than that. So on the blue and the red arrow there, you can see what the cutoff point would be for depression using this scale, the Hamilton Depression Rating Scale. And the white dots are placebo, and the colored dots are medication. And in this study, the blue line there was where they found there was a difference where drugs were more effective than placebos, and anything to the left of that, there seemed to be no difference. But that severity of depression, which is like a score of 25, is considerably higher than the cutoff for major depression, and definitely for people who have sub-threshold depressive symptoms, like scores below 16 or so, medications seem to have very little benefit. So what this means is that if you have a milder form, even of major depression, there's really no difference between the treatment and the placebo. Not to say that the drugs wouldn't have some benefit, but that you can't attribute people's improvement to receipt of the medication rather than their expectations of it. And that for major depression, it's only cases where there are more severe symptoms that medications have much effect. So I'm not saying that you shouldn't use antidepressants to treat depression, but that your expectation that the drug will have a big effect needs to be tempered by realizing that it probably will have a big effect only if there is a severe degree of depression. And if somebody has a mild degree of depression, you want to think about other approaches, some of which I will go into. So this is a little bit of a tangent, but it's useful to think through what the dose response curve is of different medications. In this case, antidepressants. So you could say like the more drug you get, the better the response is. That would be the green line. Or you could say that you after you start using it, you get some effect that's almost a full effect, and then it plateaus off. That would be the red line. Or you could say that you get no effect until you hit a certain threshold dose, and then you get a full effect, and then it plateaus out, which would be the black line. Uh, so you can spend time thinking about this, and then you realize that none of these lines are accurate. And the reason is that they go through the origin, the where the 0, 0 point. And in fact, the response rate to a dose of zero, which is placebo, is quite large across all the studies. I can go back to this scale. The white dots here are not seeing zero change. The white dots are seeing a lot of change relative to the initial value. So if you look at the real data for different types of antidepressants, you see that none of the curves are anything like those ones here, where it goes up and up and up the further right you get. In fact, it looks like they almost have an inverted U shape, where the higher the dose after a certain point, the worse the effect. But really, it's kind of like you're lucky to have any linear relationship whatsoever. So not to say that medications don't work, but that you can't expect that by adding more medication using higher doses that you are going to get more bang for your buck. This is frustrating, and I find it one of the harder, more subtle points to convey to our psychiatry residents and fellows, because it requires you to really rethink what you're doing with medications and what the potential harms are that you are inflicting on people by using doses that are not more effective, but that are having lots of side effects. And then another very interesting finding about the placebo is that over time it seems to have become more effective. So this is a study where they looked at antidepressant response rates in placebo-controlled trials. On the left is drug, on the right is placebo, and they found that between 1980 and 2010, the drug effects diminished and placebo effects increased. So it looks like about 2015 the lines were going to cross. Obviously, that's not the case, but you do see over time that placebos have become more effective, and I won't go into the reasons around that, but it is interesting and kind of unexpected. And once again, just a reminder that placebo has a huge effect in antidepressant treatment, and really, if we want our medications to work, we want to make sure that people have the best possible expectations about using them, and especially that they have a role in selecting the treatment and in guiding how it gets applied. So this is kind of the very bad news for depression treatment in the real world, in standard care. So people are seen in their primary care settings and are referred to get mental health treatment of some kind. Only about 30% of them do not show up for their first appointment. So only about 70% do go. Of those who come to a first appointment, 25% don't go to follow up. And then of those who do follow up, only about 30% get what you would call full remission. So really, you're talking far, far less than half of people who are identified with a problem, have some access to healthcare. About half of them, well less than half, get the treatment that is effective for them. And really, the overall rate of successful remission is only 19% in primary care. So that's really pretty bad. That means 4 in 5 people who are depressed are not getting better when they get usual care treatment for depression. That really demands attention. And the way people dealt with it was by building other systems of care, some of which you may have seen, but that are still pretty underutilized in our healthcare system. Uh, there's a number of barriers that get in the way when you try to understand why people don't go to their appointments and don't follow up and also don't respond. So there's knowledge and attitude issues. And then there's a lot of other things to take care of in primary care settings that often encourage starting an antidepressant and then just keeping people on it, even if they're not having a real improvement in symptoms. As I mentioned before, antidepressants have some effect, but they don't fix the problem in any guaranteed way. Psychotherapies have some benefit, but don't work as a guarantee for everyone. And really across the board, if you look at the big studies, you'd say that psychotherapy and medication has about the same effectiveness rate. And really, the problem is not whether the treatments work in a carefully controlled research space so much as whether they're applied appropriately in the world. For instance, if somebody doesn't come to their follow-up appointment with mental health, they're probably not going to get the treatments that work. So the systems that were developed, some of them at the University of Washington are known as collaborative care, and they involve integration between the patient and a primary care provider, which is usual care, but also there's a depression care manager who talks to the patient roughly once a week, checks in, sees how they're doing with their treatments, asks them some rating scales to determine what their degree of depression is, and engages in some brief behavioral interventions, especially one called problem-solving treatment, where you figure out what people want to accomplish and break it down into steps. There's a consulting psychiatrist who reviews the cases and, if medications are indicated, makes recommendations to the primary care provider, who then prescribes the medications. The consulting psychiatrist also tracks the symptom scales over time and makes a decision as to whether something needs to be changed, like if there should be more antidepressant or switch to another one. So this is the feedback loop that happens. There's the tracking of outcomes. In most of the large depression studies, they use the PHQ-9, which I mentioned. The feedback is then whether you should keep the treatment the same or adjust the treatment. And if there's not appropriate response within a period of 4 to 6 weeks, then you would go back and reassess. When collaborative care systems are applied, even in real world settings, they can produce really big differences in symptoms. So you can see here the usual care versus a collaborative care intervention, which produced rather dramatic reductions in depressive symptoms and about doubled the likelihood of attaining remission from depressive symptoms. So this really is the gold standard of treating depression. So you don't just use medications, you don't just refer somebody out for psychotherapy, but rather you have a structured monitoring and engagement tool that uses a designated care manager. I realize this may not be all that helpful if you don't have a system like this, but I do want to encourage you to know about these. And if you have any role in starting or recommending clinical programs, to get these going in the places that you work, because they really can produce far better outcomes that are more persistent than simply trying to use medications and psychotherapy on a short-term basis. So I know that's a kind of a funny approach to treatment, which usually you would go over all the primary data. But I think if you really step back, you come to see that the important thing is not picking the right drug, but rather in ensuring that the patient is supported appropriately through their process of recovery. All right, let's turn now to suicide. Uh, as I mentioned, difficult topic, often quite hard to bring up, but you will encounter patients who think about taking their lives, and once in a while you get someone who has attempted suicide, and it can be really challenging. And if you're not prepared to think about what to do in that setting, you can end up being both very frustrated and also not helping the patient in the way that they need at that moment. This is data about the risk of suicide across different ages. Pretty striking differences based on sex and race. This only categorizes people as being white or black. I don't have data on the other race ethnic groups, but the trend is similar that the um, as you get older, white males are the ones at greatest risk for completed suicide. Black males also have a high risk. Women have a lower rate with advancing age. Uh, and there's in white women, there's a peak around midlife that then decreases over time. And black women have a very low rate of suicide. As with depression, it's really hard to understand what might be behind somebody's interest in dying. There are a variety of theories that have been presented. None of them fully accounts for suicidal behavior. I think the key for me is to realize that it's not necessarily a sign of a mental illness. In fact, suicide is probably just a very misguided problem-solving strategy. So if you see that things are problematic and you don't know how to deal with them successfully, and you see that there are options A, B, C, and D, and option D is to take your life, there are times that that might seem like the best thing to do. And if you decide that, it's going to be probably a very bad decision for you. But it's what seems like the right optimal solution at that moment. So if you start from this perspective, you can help people to problem solve. Whereas if you assume someone would want to commit suicide because their, neurotransmitters are off, or they're, if they have a mental illness that's not curable, that doesn't get you very far. You're not going to fix somebody's depression by snapping your fingers, but you could help them by developing better ways of dealing with their problem in the moment. So there are warning signs to look out for. Most of these are pretty obvious. Unfortunately, for risk, finding out who's really at risk, there are a lot of people who endorse these findings who are not really going to do anything with regard to self-harm. But if you talk to people who are expressing these kind of issues, and especially if somebody has been making plans around suicide, you really need to pay immediate attention to it. There's unfortunately not any kind of single profile that a person at risk of suicide has. The only finding that they've come across in what's known as psychological autopsy studies, which are trying to investigate the mental state of people prior to completed suicide by talking to their loved ones and colleagues. What they found is that the only real strong risk factor is a new interest in the afterlife. So if somebody didn't really talk about the afterlife or existential issues, and suddenly they're talking about what what eternity is like and what happens to you after you die, that may be a great risk factor. And that, I think, kind of only makes sense. If you're thinking about death, you'd want to be able to answer some questions about what is really involved there. So these are things to look out for. The risk factors you probably have heard of. older white males, obviously from that graph, are the highest risk group. If you add on substance or alcohol problems, limited social support, major depression, and pain, the rates are even higher. But in terms of pure sociodemographic risk, it's older white males who do not have a social support, like who live alone, especially. The pain angle is very interesting. As Barb mentioned, I had done work on this earlier in my career. Uh, there are some people who work on the topic of suicide who conceive of pain as the core element that motivates people to want to take their lives. That basically they're trying to get out of pain, and that is their problem-solving approach. I just can't take this emotional pain anymore. I need to escape from it, and the only way to do that is not to be alive. So this was a psychologist, Edwin Schneidman, who was in San Francisco, and he analyzed all of the suicide notes that were collected in that area for a long period of time. And when he boiled it down, he concluded that pain really was the core element of suicide. So another thing to look out for, if somebody is talking about pain a lot, if that's part of their metaphor of their experience, especially psychological pain that's not resolving, it's especially important to assess their risk of self-harm. This connection with pain is borne out by analyses of the risk factors in completed suicides. And here you can see that the common medical conditions were not associated greatly with risk of self-harm, but psychosis was moderately so, and then depression and severe pain were quite highly associated with suicide. But oddly enough, severe pain had an even higher risk than did major depression. So pain and suicide risk go hand in hand, and you want to be careful, make sure to assess pain and emotional pain, and when you do, to make sure that people are not having suicidal thoughts. So when you're assessing suicide, I assume most of you don't work in psychiatry settings, and it may not be something that's routine. But just a few points to remember, especially if somebody happens to bring up in any random setting, I'm thinking about killing myself. What do you do? So the keys to assessing are, first of all, to realize anybody can be at risk. I had a primary care colleague who worked in Anacortes who had a very interesting story of a patient that he had known for decades, like considered him almost his friend because they knew each other so well. He had treated him for his medical problems for years. And then they got this computer-based screening tool that they used in the waiting rooms. And the first time this patient used the tool, he endorsed suicidal thoughts. And his primary care doctor had just never thought to ask him about it. And this guy said that, yes, he had been thinking about suicide for years, but just felt kind of ashamed to tell his doctor. So you don't know just based on how somebody presents. And the only way to ascertain is to ask somebody. And as a reminder, asking about suicide does not increase risk of suicidality. In fact, it decreases it. So you're not doing somebody a favor by ignoring the problem. And then you want to get an internal sense of how risky things are. You can base that off of what the patient is telling you, like, are they making plans? Are they having thoughts of dying? Are they hopeless? Do they have means? And then if they've had previous suicide attempts, that obviously increases the risk greatly. When there is a thorough assessment of suicidal risk, the assessment is definitely not perfect. Like, it doesn't reliably predict people who are going to attempt or complete suicide, but it's roughly accurate. And you don't have to have a psychological or psychiatric degree in order to assess how risky somebody is. So if you get the sense that somebody is very depressed or hopeless, you can ask the question directly. And have you had thoughts of hurting or killing yourself? It's good to practice that so that you get comfortable asking it. It can be hard at first to ask that question because it's something different than you're used to talking to people about. And if they say yes, then you would try to ascertain if they have had more detailed thoughts around this, like have you had a plan for this and what is it? And especially access to firearms is important to ascertain. And then if there's risk, you want to do something, obviously. Uh, if you're not a mental health professional, really the key is to ask for help. There's crisis lines that you can call, or in the clinics you work at, I assume that they have protocols. And if somebody really is an imminent risk, then they can be referred for involuntary treatment if they don't want to accept treatment. It's also important to document what the patient said and what your actions were. Uh, it's really crucial if you're assessing somebody who has suicidality to give an actual categorical assessment of the degree of risk. So, based on my findings, I believe that this patient is at low risk for suicide because, one, they're forward looking, two, they have no history of self-harm, and three, they said they weren't going to do anything in the short term, and four, they said they would never do this because it would hurt their kids. You don't even need the full explanation, but if you assess somebody who's suicidal, they tell you they're suicidal, and all you do is say, patient says suicidal, and you don't say what their level of risk is, you're really committing malpractice and not doing them a service. And then back to my original point about problem solving. If you were able to do one thing with a suicidal patient as an immediate intervention, it's to get them to doubt that what they are thinking of doing is a good idea. So you want them to, you can't solve their problem right away, but you want them to realize there are probably other ways to solve their problem, and especially that one solution of taking their own life is a bad way to solve the problem. So these are some sorts of things that you can say to somebody who may be experiencing a state like this. I hear you. I hear that you feel like your life isn't worth living. I'm sorry that you feel this way, but your life is important to me, and I want to talk to you more about it. So that opens the door to share things. And then after you get all the information, you can say something as direct as, committing suicide or killing yourself sounds like a pretty bad way to try to solve your problems. I heard my supervisors who were more experts in suicide than I was at the time tell this to patients, this final comment. And it would kind of freak me out because I was worried that the patient would get super distressed or angry. But it almost always has a positive uh, response. People will say, "Oh yeah, maybe that's right," or they'll try to argue with you, like, I don't know. It seems like that's the only thing I've got, and then you can help them backtrack and realize, are there other ways that you could deal with this? Oh yeah, I guess I could try something else. And really to get them to, that in order to instill doubt and to get the patient to question this, we can provide some factual information. So obviously, we don't know what happens to you after you die, but the middle point there that the children and friends of those who commit suicide are more likely to commit suicide is based on science, and that often gives people a lot of pause. So, wait, you're telling me that if I commit suicide, then my kids might, have a higher risk of committing suicide, and that's true. And when people know that, then they will often reconsider. And you can also ask if they've known anyone who committed suicide and what the experience was like for them to live through that. And they will almost always tell you, "Oh yeah, that was really terrible. I wouldn't want to wish that on anybody else." And then you could point out, but it sounds like you are in fact thinking of something like that now. And then you can also point out that given our uncertainty about what happens after death, you can resort to non-fact-based reasoning about the afterlife. And if you look around the world, the majority of people in the world think that if you kill yourself, you're going to be punished in one way or the other. And so, you don't have to believe in any particular religious tradition in order to acknowledge that this could possibly be the case. And maybe if you kill yourself, things will be worse than they were now. So that wouldn't be a very good problem-solving approach if you jumped out of the frying pan into the fire, as they say. So obviously, you're not going to fix the immediate problems that the patient is having, but you can help them to develop other ways of dealing with those problems in the short term, and in particular to help prevent them from taking this very misguided attempt at resolving the problems with this solution that you can't reverse. So real quick review of what we talked about today. So depression is a clinical syndrome. It's not just having a bad day. It's not a part of getting older. In fact, as I tried to show you, as you get older, you should expect to have a better quality of life. But that if you do get depressed as you get older, you may have a higher likelihood of getting stuck there than if you're a younger person. Depression is treatable, but a lot of the standard treatments don't work real well or consistently. And the most effective treatments are those that are structured interventions, especially collaborative care, and that using just a little bit of treatment to help a little bit of depression is not an effective strategy. And then finally, I'd encourage you to practice asking questions about suicidal patients and to be ready mentally to deal with their issues if you come across that situation. And in particular, to be ready to instill doubt in the patient about whether suicide is a good idea. Finally, a little inspiring quotation from Tom Petty that if you're not getting older, you're dead. That's I mean, boil it all down. That sure is true about the aging process. And I know this is the last lecture in the series, so this I hope is an inspiring final quotation. I'm only kidding; it's not that inspiring, but good one to keep in mind. And if you're talking to older patients, it's a fun one to drop, and usually gets a good laugh out of them. All right. And if you have any questions on any of this stuff, love to hear from you. That's my email and my phone number. And I didn't see any questions along the way, but maybe I was looking
I didn't
wrong.
see questions either. I think everyone was sort of really trying to capture everything you were saying because there's a lot of information here that's helpful. I really appreciated the more recent data that you were reporting on related to, you know, being sick versus healthy and depression and what one might expect from that with age. So that was really helpful. We got to let's see what we've got here. How to differ bipolar disorder and depression.
Oh, great question there. Yeah. So as I mentioned earlier, as a snapshot, it's really hard to tell if somebody has a depression, uh, major depression, which we call unipolar depression, or if it's a bipolar depression. So the people with bipolar depression will report just the same kind of nine, hallmark symptoms of unipolar depression as those who don't have bipolarity do. So really, the key is to get additional information from loved ones, especially who can tell you if the patient has had times in their life where they seem to be the opposite of depressed, or were revved up, or didn't need to sleep, or spent way too much money, or were hypersexual. Uh, it can be hard to tease this out. And unfortunately, patients are terrible at reporting this data uh, by themselves. Because when you're feeling good, you're feeling good. You're not considering it to be an abnormal state. So, in my clinical experience, I've had quite a few older patients who I was treating who had been taking antidepressants for their whole lives. They really never got better with antidepressants, and then we would get information from their families that suggested they had episodes of hypomania, never full mania, or you would probably have known about it. And we started them on treatments for bipolar disorder, especially a drug called lamotrigine, and these patients would feel more level than they had in their whole lives. So, as I mentioned, it's important to make this differentiation because the treatments for depression are totally different than the treatments for bipolar disorder. And if you're mistreating one or the other, you're really not helping people out. So that is a great question, and unfortunately, you kind of have to monitor people over time and assess. Sometimes you see it happen yourself, but if you can get other information from collateral, that's a better way to do it. So there's a question about placebos becoming more effective over 20 years. Great question. And I said I wasn't going to go into it then, but I will now. It's a good thing to know about drug approvals. So when I present this data, especially to the residents, about placebo becoming more effective and ask why, they'll think that it's related to marketing largely, like direct to consumer marketing, which may have some effect. If you see those drugs for the little bouncing smiley face, you might expect that antidepressants have more power. And so if you're taking one or a placebo, you'll get a better response. But I think there's a more clear explanation in how studies were carried out, which in the old days, drug companies had a lot of leeway in how they could design their studies in terms of inclusion and exclusion criteria. So they were able to, kind of bring in the patients that they knew might have more of a drug response and less of a placebo response. There are personality type characteristics that are associated with placebo response. And they would kind of nudge the studies in those directions. And also in the old days, you could do a bunch of drug studies and then publish only the positive results. So if you did 5 studies of your antidepressant and 2 of them were positive and 3 of them showed no difference between drug and placebo, you would only publish the 2 that showed the positive result, and that would make it look like the drug placebo difference was bigger than it was. Nowadays, since about 2000, you have to pre-specify the studies you're doing, what the outcomes are, and you have to provide all the results to the FDA, which means that there's many more negative studies that get included in the overall data analyses. So that's a little explanation of why placebo has become more effective. And the question about whether non-pharmacologic therapies being used increasingly, that's another great topic. Overall, the use of non-pharmacologic therapies has not changed much, which is a bummer. It'd be great if we had more access to behavioral and psychological approaches. And when you ask patients what they would like to do, uniformly patients prefer not medications. I mean, they want to have a talk therapy or a group therapy or a behavioral therapy, but access to them remains difficult. There has been some increase with the use of telemedicine approaches, but even then, access is quite a problem. So, super question, and that's one of the kind of system challenges that we have, that we're not able to provide the type of treatment that people would want on a broad scale.
That's
So,
very
oh
interesting. We also have a question from Ivan that asks
yeah,
what percent of patients have only late onset MDD?
great question. So yeah, I didn't address this because it gets a little bit of a field. So as I mentioned very initially, the likelihood of having a depressive episode is based on the number of prior episodes. So if you had one episode of major depression in your life, you have about a 40% chance of having another, 40 to 50%. If you've had two episodes, it's more like 70, 80%. If you've had three episodes, then it's 90 plus percent. So the major depression is a recurrent disorder, and if you've had one episode, it's going to make it more likely that you have another. What that means in the aging process is that if you've survived to 60, 70, 80 without an episode of depression, it's unlikely to happen. And I can't remember the exact statistics, but I think it is about 15% of cases of major depression happen after age 65. But what you often see is that the people with this clinical presentation are not really experiencing mood problems so much as cognitive problems. And it's like that case I mentioned where the family is worried about the patient because they're not doing things. So people have apathy. They don't do their activities they used to do. Their sleep rhythm can be off. In early dementia, there's often weight loss that happens. So people's appetite is decreased. And when you follow people over time, what looks like a depressive episode actually is a cognitive impairment. So one of my more senior colleagues here who's worked in our inpatient unit for a long time feels that whenever we get a patient who's over age about 70 who's having a first episode of what looks like depression, it more likely than not is a form of early dementia rather than being a new onset mood disorder later in life. I'm certainly not saying that doesn't happen, but that it's something that needs to be separated out from other causes, and not just treated simply as if somebody developed depression for the first time in their lives when they were older. Bipolar disorder, however, is interesting because even though most people develop bipolar disorder in their 20s or so, uh, you can have a new onset of bipolar disorder at any age of your life. And once in a while, we will see people who are in their 70s who have the first episode of mania, which is just really bizarre to me that you could go that long and then all of a sudden have this pretty severe change in your behavior and mental state. But sure enough, it does happen. So if somebody is showing any evidence of hypomania or mania along with depression, you have to consider if they have a late onset bipolar disorder.
Interesting.
So, David, great question about the characteristics to produce placebo response. I believe there is a questionnaire that's used around this. I'll have to look it up. But it's kind of the ones that you'd expect would predict people having a positive response to things that are more based on suggestion. Certainly very different than like gullibility. But if you believe in the power of natural healing, or you believe in your mind's ability to control things or heal disease, you're much more likely to get a response. And there's the topic of placebos is super interesting if you ever want to read up more about it. There is evidence that opiate blocker medications like naloxone or Narcan can block the placebo response. So you can stop people from having a placebo effect in the short term if you give them a drug that blocks opiates. So it indicates that the placebo response is probably mediated in your brain by opiate medications, and that the sensation of using opiates may be something like the positive response you get with placebo. Great question. Ivan, another question about undiagnosed frontotemporal. Absolutely, yes. So frontotemporal dementia is an interesting condition. Tends to initially not involve many cognitive changes. So depending on the type, you can get some forms that are lateralized, especially those that have left-sided frontal impairment at first, which is degeneration of the left frontal lobe. The syndrome can look a great deal like depression because people just seem to be totally apathetic. Like they'll just sit there and do nothing or kind of say, I don't care. But then if you really do inquire about their mood, they will tell you, I mean, it's fine. What are you talking about? It's really weird to deal with these patients. We had a group of them at the VA who look like they're super depressed but deny really having any depression. And a lot of them had been categorized as being depressed. And then as they were followed over time, it became clear that they were having cognitive and other behavioral changes. And when they finally got some neuroimaging, it was clear that they were having frontal lobe degeneration.
Interesting. Very
Yeah, thanks.
interesting.
All right. Well, thank you for all those questions. That was great. And you got my contact information. Just feel free to email or call me. And thank you for joining today, and thanks for coming to the series. And Barb, thank you for inviting me.
Thank you so much. Always, Dr. Thielke. Really, really appreciate it. Everyone have a wonderful summer, and thanks for your participation over this series and the winter series as well.
Thank you. Bye bye.
Bye bye.